Hi guys, welcome to our channel. Today we're going to be going over cardiology meds, and so we have them all listed here on our whiteboard. I'm going to go ahead and start down here with ACEs and ARBs. So one thing to remember with this first category here is just kind of what the ending of those meds is. That way when you see them, you can distinguish between whether it's an ACE or an ARB or another type of med. So with ACEs, you want to remember pril, so they typically end in pril, such as lisinopril. And then with ARBs, they usually end with sartan. And so over here we have a few things that you should know in regards to those meds. So one thing is that these are cardio and renoprotective meds. Another thing with the ACE is that it can cause a cough. And so the reason for that is that you're blocking bradykinin. And so if your patient comes in, they complain of a cough, they've been taking cough syrup, it's not working, you go ahead and just switch them over to an ARB. It's going to have the same effect.
Block bradykinin breakdown, so more brady.
So what's happening is that bradykinin is being blocked. Therefore, the breakdown is being blocked, so you're having more brady, and that's what causes that cough. So again, if they come in complaining, just go ahead and switch them over to an ARB. This can also lead to
Angioedema.
And an increase in potassium, and this is for both the ACEs and the ARBs. So now we're going to go ahead and move over to diuretics. So your three categories for diuretics is going to be thiazides, loops, and case-sparing. One thing to note is that case-sparing can also be referred to as aldosterone antagonist. And so a few of the names of the meds that we went over with this lecture was that thiazides, we have hydrochlorothiazide, also known as HCTZ, and then we have loops, so those could be like Lasix, and then with your case-sparing, spironolactone is the most common. You want to be aware of electrolyte imbalances that occur with these meds. So you could have a decrease in sodium with your thiazides. You can have a decrease in potassium with your loops and your thiazides. And then we can have an increase in potassium with case-sparing, and that's the whole purpose of case-sparing, so you can remember it that way. And then you have an increase in calcium with your thiazides. So now we're going to go ahead and switch over to the other meds, and we have Shannon take care of that.
Okay, hey guys, so today we're going over some more cardiology meds. So we're going to start with alpha, and then we'll go beta, and then calcium channel blockers. So the way I remember alpha-1 is a blocker, is that it ends in zosyn. And then alpha-2 agonist is methyl-dopa and clonidine. So I just remember zosyn, MIC, AIM, and SPIN. It's kind of stupid, but it's a little hard. I think sometimes people get mixed up, like alpha-1 agonist, antagonist. So just think alpha-1 blocker, you have end in zosyn. One drug that we see with this is tamsulosin or Flomax, and that treats benign prostatic hyperplasia, BPH. So if you say alpha-1 blockers, think BPH treatment. And then alpha-2 agonists, we have the methyl-dopa and clonidine. Methyl-dopa is first line antihypertensive for pregnant women. And then clonidine, two things to remember with clonidine. I remember them with a down arrow and an up arrow. The first is that you have first drop hypotension. So the first time someone takes clonidine, they might just kind of drop their blood pressure really low. So be cognizant of that. And then there's also rebound hypertension. So after you stop taking clonidine, you might get your hypertension might come back. So we don't really use it much anymore, but just remember the down arrow and the up arrow. That'll kind of help you remember to a side effect and both side effects with that. So moving on to beta blockers. When we talk about beta blockers, we have to remember that beta 1 is the AV node, whereas beta 2 is the myocardium and the coronary arteries. So just remember beta 1 is going to be the one that really works on the heart rate, whereas beta 2 works on other things in the heart, and then it does kind of systemic vasoconstriction. So when we're blocking the beta 1, I remember AIM, and then beta 1, beta 2, non-selective, SPIN. So you AIM, beta 1 when you're trying, it's cardioselective, so I remember you select, you AIM, whereas beta 1, beta 2, when it's like, you don't care if it's beta 1, beta 2, which is both, but just remember, then you remember SPIN. So the AIM is atenolol, metoprolol, and esmolol. So those are beta 1 blockers, and those just block the AV node. And then SPIN is sotalol, propanolol, and nebivolol. So which ones would be better for COPD patients? It's going to be the AIM, because with beta 2 blocking, we're blocking the bronchodilators. And so that's bad because a beta 2 function is bronchodilation. So we're blocking bronchodilation. That's going to be really bad exacerbations for asthma or COPD patients. Another thing with beta blockers is we have a black box warning for a 2-week taper. Never abruptly take your patient off a beta blocker. You need to taper it. So another thing that we have are calcium channel blockers. So with these we have two classifications, DHP and non-DHP. So DHP, this means dihydropyramide, these are our vascular ones, whereas non-DHP, that is an AV nodal blocker. So DHP, the brand name is Norvasc, and the drug is amlodipine is one of them. So if you forget, like, is DHP or non-DHP the vascular one, you can just remember Norvasc is the vascular one and Norvasc is DHP. So that's a good memory trick. And then our non-DHP drugs is diltiazem and verapamil. So DHP, an indication, there's quite a bit other than antihypertensive, but another indication is going to be for prince metal angina. So it's just kind of something you have to remember. We thank my Norwegian prince to remember Norvasc, prince metal. Another thing, you get reflex tachy, except for Norvasc. So that's probably why Norvasc is the most commonly used drug within this classification. But reflex tachy is when you drop your patient pretty low with antihypertensive, and then their pulse shoots up to try to compensate for the low blood pressure, so they get really tachycardic. Another thing with DHP with Norvasc, you can get gingival hyperplasia. So if your patient already has a problem with overgrowth of their gums, do not do this. And so we remember this, that Norwegians have thick gums, gingival hyperplasia. Another one, you get angioedema. This makes sense because DHP, Norvasc, vascular, it's a vasodilator. With any vasodilators, you're going to get that angioedema probably. So that is DHP and non-DHP. So these are some of our antihypertensives. We also have direct acting and a couple other groups that we didn't go through, but those ones are less common. So these are going to be your big cardiology meds.